Hello, are we good to go all? Good evening, everyone. My name is Abimbola Ajayi, and I'm the Executive Director of Administration at Renaissance Medical Center. It is my deep pleasure to welcome you all to this maiden edition of our webinar series. And today we shall be looking at the topic rectal bleeding. Those of you that know us at Renaissance Medical will know that the issue of rectal bleeding is very close to one of our core specialties. As you might very well know, we're a leading center in the practice of endoscopy here in Nigeria. Just a few introductory remarks really before we get to the crux of the whole matter. You might be asking, why this? For us, this series that we're starting today is nothing more than the continuation of our attempts at meeting our corporate social responsibility towards the society. Those of you who are familiar with us will know that we have been on air, on radio, on television at on various occasions, generally talking about health-related issues. And so we're just extending it now to this particular forum. We don't have to preach to the converted, because quite a number of you already know who we are at Renaissance Medical. But I'll just tell you a couple of things about tonight's presenter. Tonight's presenter is Dr. Dayo Ajayi. He is our Medical Director and Chief Executive Officer at Renaissance Medical. He is a medical practitioner of some, not so many years, maybe just 40 years plus experience, trained both here in Nigeria and in the United Kingdom, where he has actually done much of his practice. He is a fellow of the Royal College of Surgeons, a fellow of the West African College of Surgeons, a general practitioner in the UK. He's a member of the American Society of Gastrointestinal Endoscopists, and I could just talk on and on, but I think you all have a fair idea of the kind of person that will be telling us about rectal bleeding tonight. So without too much ado, I think the only other thing to add is that this is going to be fairly interactive, but we'll do it in such a way that it will not our questions and all that will not disrupt the flow of the whole proceedings. So those of you that have questions should please put in your questions through the chat option. Okay, your questions will be collated and they'll be answered after Dr. Ajayi's presentation. And then there will be also at the end of it all a question and answer opportunity for live questions. So without much ado, ladies and gentlemen, I call upon Dr. Dayo Ajayi to give us the walks, as it were, on rectal bleeding. Thank you.
Good evening. Good evening, all. Thank you very much for finding time in your busy weekend schedule to attend our webinar. I feel highly honored and flattered by that introduction. Be that as it may, I think this is a very important topic that we're talking about. For the mere fact that rectal bleeding, as innocuous as it may sound, could be a harbinger of malignancy in the rectum and the colon. And there's no way you can differentiate between malignant and non-malignant causes without being investigated. So that is the essence of gathering here tonight to talk about this very important topic. This is a Team Renaissance. You can see the camaraderie that exists in their environment, despite the seriousness of business. So a very simple way to categorize bleeding rectally is to categorize heavy bleeding and non-heavy bleeding. It doesn't necessarily matter whether it's light or whether it's heavy. In other words, what I'm saying is that even malignant causes can present with even the slightest bleed. Another way of categorizing rectal bleeding is to differentiate between bright red bleeding, maroon bleeding, and melena, which means black stool. I will be showing you a diagram later on, which with an explanation on why some people present with bright red blood rectally, bleeding rectally, and other people present with maroon or black stool. In other words, it depends on the length of travel along the length of the bowel. The longer it stays in the bowel, obviously, then the more the digestive enzymes act on the blood to turn the color from bright red to dark red or black, depending on whether to stay there for that long or not. For you, this is just a diagram of the large bowel. So the large bowel is divided into three parts. The right part, which will be to your left since you are facing the screen, and then the middle part, which is the transverse colon, and the left part, which will be to your right as you're facing the screen. It does not take much to imagination to note that if the bleeding is from the right side, there is more time for the enzymes to act on the blood before it passes out through the rectum, and therefore the color will be darker if it's coming from the right as opposed to coming from the left side, where it will be brighter, right? I will just go through the common causes of rectal bleeding. It is a very rife practice for people to just assume that bleeding from the anus is from hemorrhoids. Like I said earlier on, that's because even the nastiest things may not present with any other symptom apart from the bleeding through the rectum. So yes, hemorrhoids are by far the commonest cause of bleeding from the rectum. In fact, it is safe to say that in more than 95% of cases, bleeding rectally is from hemorrhoids. But like I said, there's no way you're going to be able to distinguish between bleeding from hemorrhoids and bleeding from nasty things like cancer unless you subject yourself to examination. Infections can also cause bleeding rectally, especially in our part of the world. You have some infections in the bowel that can present with bleeding, blood in the stool. Inflammation. There's a difference between infection and inflammation. Inflammation, the two typical diseases that fall under this category will be ulcerative colitis and Crohn's disease of the bowel. Luckily, these are not very common in this part of the world, but in Europe and North America, these are quite common. The most important thing that we want to rule out are tumors, because they can present with rectal bleeding and no other symptom. Note that I'm categorizing tumors together. In other words, non-malignant tumors and malignant tumors. Diverticular disease of the bowel or the colon can also present with rectal bleeding. Quite often, this bleeding could be very brisk and heavy. Diverticuli are pouches that form in the bowel, and because the points at which these pouches form are the same points where the blood vessels enter the bowel. So that explains why many times they can present with heavy bleeding. Other causes which are not so common are vascular malformations. And it is worth noting that anal fissure can also present with rectal bleeding. This is usually accompanied by severe pain in the anus. Severe pain in the anus. I will also talk about hemorrhoids at this stage because hemorrhoids do not usually cause pain. When they cause pain, then those hemorrhoids are complicated. But the pain with hemorrhoids it's not on the same scale as the pain experience with anal fissure. By the way, anal fissure just means a linear ulcer in the anus, which is quite often precipitated by chronic constipation. So we just talk about tumors. I'll just categorize. Tumors just mean swellings. It doesn't necessarily mean cancer. So yes, cancerous tumors are the worrisome category. Then we have, in particular, talking about bleeding from the colon, we have what we call polyps, which are well recognized as being precancerous. In other words, they may start as non-malignant tumors, but if they are there unnoticed and unattended to over a period of years, they will surely, in most cases, become cancerous in the end. And of course, you have the non-cancerous tumors, which are just maybe inflammatory swellings in the bowel. So most polyps are precancerous. And like I have emphasized tonight, you are not likely to get any symptom whatsoever from polyps except bleeding. And because it's difficult to know which bleeding is coming from cancer, which one is not coming from cancer, that is why it is important to take rectal bleeding seriously and subject yourself to examination and, in particular, colonoscopy. Colonoscopy is the art of intubating the anus, passing a tube with a light source at the end, with a camera at the end as well, obviously with the bowel fully prepared, in other words, completely evacuated. And these passes on images to surrounding screens. And this affords us the opportunity to visualize polyps if they're there, and affords us the opportunity as well to remove these polyps through the endoscope, through the colonoscope. This is a picture of our front room, endoscopy room. And when it's in action, you can see the team in action. I'd like to emphasize that this picture was taken during the pre-COVID era. Nowadays, if we're going to do colonoscopy, we do it with a full PPE donning. This is a picture of a polyp, which was found in one of our patients. And you can see it doesn't really look nasty, but it is sizable. And if you leave it there for a while, for some time, it tends to generally become more aggressive and more angry looking. You can see the difference with the next slide, the picture on the next slide, and this. You can actually see, you don't have to be a medically trained person to note that this one looks nastier than the previous one. So, to cap it up, if you're bleeding rectally, you need to see a specialist who knows how to investigate rectal bleeding. So you consult, you get examined. Proctoscopy just means you're passing a scope into the rectum, which is usually just a few inches long, shining the light source through it to see whether the stent is coming from within the rectum or not. But the full examination will require a colonoscopy, that is passing the scope through the whole of the colon, which, like I said earlier, affords us the opportunity of diagnosing the cause of the bleeding. And in many cases, when they're just at the polyp stage, we can actually remove the polyps through the scope. And if they've already turned nasty, then it also gives us the opportunity to biopsy the lesion and send specimens to the laboratory for histology. And that is what will tell us whether it's cancerous or non-cancerous. But it is well recognized that when you subject yourself to colonoscopy at the very early stages, you see a polyp and you remove it, you are definitely preventing cancer. In fact, in many parts of the world, once you reach the age of 45, 50, you are encouraged to routinely subject yourself to what we call screening colonoscopy. And If you come from a family with a history of colon cancer, in fact, you are encouraged to subject yourself to colonoscopic examinations even much earlier, as low as 20 or 30s, depending on how common colon cancer has been in the family, or whether there's evidence that there's a familiar trait in the family for colon cancer. Thank you for joining us tonight. I'm sure many people will like to ask questions, and we'll be quite happy to provide you with answers. Thank you.
I very much believe that participants have gained a few things. And without much ado, let me just hand it over now to our technical crew to start unraveling any questions that might have been sent in. Well, are you there?
Good evening, everyone. Thank you very much for joining in on our webinar. If you have any questions, you can type it in the chat box. As you can see, someone has a question that just popped up now. But if you want to ask the question live, you can raise your hand. There's a feature on Zoom that allows you to do that. So where you click to unmute yourself, you would see an option to raise your hand, and you can ask a question from there. So while we're getting ready for the live session, the live Q&A session, we will now go on to the questions. I'll be reading the questions out, and Dr. Ajayi is going to answer the questions. So the first question is from Muturaya Adereti, and she says, "Thank you for this talk, doctor. What are the symptoms of polyps? What should one look out for?"
Thank you. Like I said in the presentation, quite often you don't get any symptoms from polyps. And that is the reason why when you reach a certain age, we encourage you to have screening colonoscopies. But they can also present with bleeding through the rectum. They can also cause abdominal pain. And obviously, by the time you're getting other symptoms like weight loss, that calls for a lot of worry, because quite often they've turned nasty. In other words, they've become cancerous.
All right. Since that answers the question, we're going to move on to the next question, and this one is from Chris. He says, "Good presentation, sir. Much appreciated. How often should you have a colonoscopy?"
I did mention that briefly earlier on, that by the time you reach the age of 45 or 50, where opportunities are there, you should go for screening colonoscopy. But I'm quite cognizant of the fact that the practice and the guidelines differ across the Atlantic. In the UK, you're encouraged to do, obviously because the health system is financed solely by the NHS, which is government sponsored. So if you ask everybody to come in for colonoscopy, they'll be swarmed and they won't be able to cope. So now the practice is that you are sent, they test your feces to see whether there's blood there. And then it's only when it's positive that it's sent for you for colonoscopy. Across the Atlantic, however, I think colonoscopy is still much more favored over testing the stool for blood. And this is because, not just because the financing of health is different in America to Europe, but also because colonoscopy affords you the opportunity to actually see the lesions and remove the polyps at the same time.
Thank you very much for that answer, Doc. Now from the Instagram Live on our official Instagram page, there's a question The question is, how do you know if you stool blood?
Well, we are talking about macroscopic loss of blood. I've just mentioned microscopic, in other words, that you cannot see. But if you test the stool, it can be detected. Our talk here tonight is macroscopic. In other words, whether be it a slight blood trace when you wipe your butt, or whether you actually see it in the bowl, in the toilets, bleeding rectal rectum is bleeding. So no matter how slight it is, you should take it seriously.
Thank you very much. We have another question again from Faye A. Thank you for a wonderful presentation, sir. If polyps are found and removed, how often should the patient come back for repeat colonoscopies after?
The current recommendation is that actually, if once the polyps are removed and they're non-malignant, that you don't need to subject yourself to repeat colonoscopy for another 5 years. But most of my patients within 3 years, they're eager to come back for repeat colonoscopies, obviously because our practice is a private facility.
Okay. Now someone else is asking, Motunraya Adireti says, can you please advise on the cost implications of having a colonoscopy?
Well, it isn't a cheap venture. I know that. I know that I can say that even in the UK, you will be spending, if you are doing this privately, you will be spending nothing less than 500, 600 pounds, or even up to 1,000, depending on where you're having it. By the time you add all the administrative charges and everything. Here in Lagos, of course, it's not going to cost the same thing if the facilities are there in the smaller centers outside Lagos, but you are going to spend roughly about 200,000 naira in total.
Okay, thank you very much. Chris would like some clarification. He says he's not sure exactly how often you should do a colonoscopy. So should you do this every 5 years or 10 years?
No, I've just said if you've gone for screening colonoscopy and you had polyps detected and they are benign, the current recommendation is that you do not necessarily have to do repeated before 5 years. But I have patients who are eager to come from their repeat colonoscopies even much earlier than that. The practice also differs across the Atlantic, like I said, because of cost implications in Europe. But in the private sector, we encourage our patients 3 to 5 years at least come for your routine screening colonoscopy.
Okay, now we have a live question here from one of the participants on Zoom.
Good evening, Dr. Ajayi. Thank you so much for your presentation. So I'd like to ask if surgery is necessary for rectal bleeding.
Well, surgery will only become necessary if you find more than a polyp. If it's a polyp, quite often you're able to remove the polyp through the colonoscope. But when you have very big tumors and polyps, especially those that have wide base, if you can do what we call endoscopic resection. But in cases where they're much bigger than that, then you may still have to have surgery to remove that part of the bowel that has the polyp. Obviously, if it is a cancer that's already formed, then you're going to need surgery anyway as part of your overall treatment.
Okay, thank you. We have another question here from our Zoom live chat. It goes, when polyps are snared, is there any chance of regrowth? I would think that excision is the best option.
Well, snaring is a form of excision. Yes, when you are snaring them, you must try as much as possible to remove the stalk. Because if you don't snare the polyp, the stalk of the polyp, it may regrow. But the stalk is the most important part of this polyp to subject to histology. In other words, the laboratory examination. just to make sure that it hasn't gone cancerous.
Okay, we have one more question from the Zoom live chat. It says, how often should someone with Crohn's disease have a colonoscopy?
Well, with Crohn's disease, you don't need to have more than once in 5 years. Because the incidence of cancer in Crohn's actually is not as much as the incidence of cancer in ulcerative colitis, which is the one that you need to be screened 3 to 5 years.
All right. So another person is asking a live question now from the Zoom.
Thank you, Dr. Ajayi. So I've heard colonoscopy is quite painful. Could you please let us know if it actually is painful or if people just exaggerate?
It is. There's no doubt it is an uncomfortable experience. But in the US, you find that in most cases, they actually put them out. In other words, they give them intravenous anesthesia. And the commonest agent they use is propofol, in which case then you need to have an anesthesiologist with you as well. So that escalates the cost of the procedure. In the UK, the commonest practice is to sedate the patient and to give strong intravenous analgesics. But in instances where I anticipate that my patient is not going to be able to tolerate the procedure despite the intravenous sedation and intravenous anesthesia, then we give them what we call dissociative anesthesia, in which case they're not aware of what we're doing. So yes, pain is it's something that varies from one person to the other, so the pain threshold. So good practice is to assess the kind of patients that you know that would definitely need to be given intravenous anesthesia during the procedures, and those who can tolerate with just sedation and strong painkillers.
Okay, thank you very much. I think this is going to be our last question. It's coming from Linda, and she's asking, how long does the colonoscopy procedure last?
On the average, it lasts about 30 minutes. It could be less, could be more, depending on how difficult the procedure is from patient to patient. But averagely, it lasts 30 minutes.
Okay, do we have any more questions from our Instagram, from our guests here on Zoom? Okay, a question just came in now. Is the polyp being snared painful?
No, it isn't actually, because the polyp quite often is inside the colon. The painful part of the bowel, the large bowel, is actually the external part, that is the anus, because that's where the skin transforms into the mucosa, and that's the most painful part of the bowel. That's why if you have ever had any operation like a hemorrhoid operation, or it's quite a painful experience, yes. But inside, no, it doesn't add any more pain to the procedure.
Okay, thank you so much for tuning into our live Q&A session. We are going to hand over to our host for his closing remarks. Thank you very much.
Thank you.
Well then, everyone. it's amazing that it's already 8 o'clock. How time flies when you're having a meaningful conversation. On behalf of all participants, on behalf of Renaissance Medical Center as a body, we thank you very much, Dr. Ajayi, for your presentation. Like I said at the very beginning, by the grace of God, this is the first of lots and lots of presentations of this nature. Dr. Mbaba, I see you are in attendance, so thank you. I see quite a number of Renaissance people are online. Guys, we got our work cut out for us. We got to educate the public more and more. all because, as we say at Renaissance, because your health matters. So thank you very, very much for your time, both the presenter and everyone that's attended. We see you soon, and hey, stay well. Thanks very much. Bye-bye.
Thank you for creating time in your busy social and work schedule over the weekend to attend our first webinar. We hope you've picked valuable points and you're better enlightened as to the causes of rectal bleeding and what needs to be done. Thank you, and God bless.